fracture is make sure you're treating their osteoporosis if they have it. So in a board question with a patient who has one of these fractures and they ask you what to do, the answer could be to screen or test the patient for osteoporosis. And then there are surgical treatments available in severe cases. Some of them are known as vertebroplasty or kyphoplasty, and these are usually only required in severe cases. Okay, next let's talk about spinal cord compression, which is a very dangerous cause of low back pain. This can occur due to trauma, but often it happens due to malignancy that is spread to the spine or from an abscess in the spine. And we'll talk in a little bit more detail about these two causes of spinal cord compression in just a minute. When a cord compression is not caused by an acute trauma, it presents as gradually worsening back pain, and classically the pain is worse when lying in bed at night. Pain that presents in the low back with these features should make you worried about cord compression and something like malignancy or abscess. In addition to the low back pain, patients can have symmetric lower extremity weakness, and this is always a red flag for a serious cause of low back pain. In terms of reflexes, if a patient has an acute spinal cord compression like from a trauma, they can present with diminished or absent deep tendon reflexes. But when patients have a more chronic cord compression, like from a slowly growing malignancy or abscess, they can present with hyperreflexia with a positive Babinski sign. And then anytime you think a patient could have a cord compression, this requires an urgent MRI. It's one of the red flags we talked about earlier that merit imaging of the spine in a patient with low back pain. A neoplastic epidural spinal cord compression, sometimes called an ESCC, is a form of spinal cord compression caused by cancer metastasis. Most often this occurs when patients have prostate, lung, or breast cancer that has spread to the spine. And the major clinical feature when someone has a metastasis to the spine is back pain. They can present with severe back pain at the level of the lesion. It progressively worsens over time as the mass grows, and it tends to be worse at night, just like we talked about in the last slide. And then if the metastasis is advanced, then the patient can have motor or sensory loss. This can involve the arms or the legs depending on the level of the lesion. And once again, neurologic deficits like motor or sensory loss are a red flag in a patient with low back pain that always merit further workup, usually meaning imaging. The most common location in the spine for an ESCC is in the thoracic spine, and the diagnosis can be made by imaging, usually with an MRI. And you should be aware that initial treatment, once you identify a metastasis in the spine causing a cord compression, is often with glucocorticoids. These are used for patients who have neurologic deficits. These drugs are anti-edema, and so they can decrease the swelling, and this can improve and sometimes salvage neurologic function. Beyond glucocorticoids initially, definitive treatment depends on the tumor type. Some tumors are treated with chemotherapy, others with radiation, neurosurgery, or a combination of these three. And then an epidural abscess is another potential cause of a cord compression. This refers to an abscess that develops in the epidural space around the spine, and this can happen by several mechanisms. Sometimes bacteria reach the spine through the bloodstream from another site. This is called hematogenous spread. There can also potentially be direct extension of infection from other infected tissue nearby, like for example if the vertebrae are infected, that can lead to an abscess in the epidural space. And then you can also potentially develop an epidural abscess by direct inoculation from a spinal procedure. So if a needle is placed into the spine, it can introduce bacteria leading to an abscess. Some of the important risk factors for epidural abscess are shown here. These include injection drug use, which can introduce bacteria into the bloodstream, also dental abscesses and infected catheters, which can introduce bacteria into the bloodstream. Endocarditis is a risk factor, and then patients who have spinal interventions, especially epidural catheter placement, are at risk for later developing an epidural abscess. The clinical features of epidural abscess include fever, back pain, and neurologic deficits. And so in any patient with back pain, if they have fever or neurodeficits, these are red flags that usually warrant imaging because the patient could have an abscess. You can also find elevated ESR or CRP levels on blood testing. These are markers of inflammation. And the diagnosis is usually made with a combination of blood cultures and MRI. The blood cultures are done because usually these patients are bacteremic, and you can identify the specific bacteria and its antibiotic sensitivities from a blood culture. And then an MRI makes the diagnosis of the abscess and finds the location. The treatment is with antibiotics plus surgical decompression. The most common pathogen is Staph aureus. This is also a common pathogen for bacteremia and endocarditis. And initially, if you don't know the bacterial sensitivities, treatment is usually with vancomycin plus a third or fourth generation cephalosporin antibiotic. These drugs give broad coverage, including coverage of possible MRSA. And then related to an epidural abscess is another type of infection involving the spine called vertebral osteomyelitis and discitis. This refers to either infection of the vertebra of the spine or the intervertebral disc. And usually when this happens, it's due to hematogenous spread, where bacteria enter the bloodstream and reach the spine through the bloodstream. Less commonly, it can occur from contiguous spread. This sometimes happens, for example, if patients have an infected pressure ulcer in the sacrum. This can lead to osteomyelitis or discitis involving the sacral spine. When patients have this type of infection, they present with back pain that's worse at night. They can also have tenderness of the spine, fever, and a high ESR or CRP. Now, you can also see many of these features in an epidural abscess, but in osteomyelitis and discitis, there are usually no neurologic deficits unless this infection has progressed and become complicated by the development of an epidural abscess. So the diagnosis of these conditions is suspected based on clinical features, and these are the same clinical features as for epidural abscess, things like fever, back pain, or tenderness of the spine to exam. Any of these findings in a patient with low back pain suggest possible infection. It could be an epidural abscess, or it could be osteomyelitis or discitis. The diagnosis is made by imaging like MRI plus cultures, so the imaging can show evidence of infection in these locations, but it won't show an epidural abscess if it's an isolated case of osteomyelitis or discitis. And then for cultures, you can sometimes identify the pathogen by blood cultures, but there are some cases where a tissue biopsy of either the disc or the spine is necessary. And the treatment is similar to epidural abscess without the surgery. It's simply antibiotics. Once again, the most common pathogen is Staph aureus, and these are usually the initial antibiotics. And then you can tailor the antibiotic therapy once you have the culture results and you know the sensitivities of the bacteria. And then I'll finish this video by talking about the cauda equina and conus medullaris syndromes. Both of these are clinical syndromes that result when there's compression of multiple nerve roots near the base of the spinal cord. They're both neurosurgical emergencies, and so any patient with evidence of one of these syndromes who has low back pain has a red flag that's an indication for urgent evaluation and often urgent imaging. So the spinal cord ends at about the L2 level. This is called the conus medullaris. This is shown here in this cartoon on the slide. And then beyond this region, the spinal nerves continue inferiorly, and this is called the cauda equina. And that's what's shown here, all these nerve roots that are continuing inferiorly after the spinal cord has ended. And the cauda equina, shown down here, contains 18 nerve roots. There are motor and sensory nerves to the lower extremity. There are also nerves that innervate the pelvic floor and sphincters of the pelvis. And so either of these regions, the cauda equina or the conus medullaris, can become compressed through a number of mechanisms. This can happen from a massive disc rupture, from trauma, from a tumor. You can also sometimes see this in children who have neural tube defects. We'll talk about the clinical features of cauda equina and conus medullaris syndrome separately, but you should know that in actual practice, the clinical features often overlap. And as I said earlier, any evidence of one of these syndromes is a neurosurgical emergency. So the cauda equina syndrome occurs when there's a lesion anywhere from L2 to the sacrum, and this can be caused by a herniated disc, and when that happens, sometimes the cauda equina syndrome presents with a gradual onset of symptoms. So patients can present with low back pain radiating to one or both legs, but then beyond this, they'll have lower extremity weakness all the way to flaccid paralysis, depending upon how much nerve disruption has occurred. You can also see lower motor neuron deficits with hyporeflexia on reflex testing. And then because these nerves innervate the pelvis and the sacrum, you can see bowel or bladder dysfunction. Patients can either have retention of urine or incontinence of urine or stool. Another classic finding is saddle anesthesia, which is loss of sensation around the area shown here on the slide. And then in men, you can also see sexual dysfunction. And so low back pain radiating to one or both legs is common, but these other symptoms here are rare, and these are all red flags that suggest a possible cauda equina syndrome. And as I said earlier, that's usually an indication for urgent evaluation and imaging. And then the conus medullaris syndrome occurs when there's a lesion at the L1 to L2 level. This is more often caused by trauma, and because of this, it often presents with a sudden onset rather than a gradual onset. Patients can present with anesthesia. It's often more localized around the anus rather than more generalized saddle anesthesia. And there can be motor weakness, but it's often less severe compared to the cauda equina syndrome. Sexual dysfunction in men is more common with the conus medullaris syndrome compared to the cauda equina syndrome. And then in this syndrome, because the spinal cord is damaged, not the nerve roots beyond the spinal cord, you can see upper motor neuron deficits and you can see hyperreflexia. And so in a board question, hyperreflexia may be a clue that they're talking about the conus medullaris syndrome rather than the cauda equina syndrome, which more often causes hyporeflexia. And so the main thing to know about these two syndromes is that clinical findings associated with these syndromes are always red flags in a patient with low back pain, and they're almost always an indication for urgent evaluation and usually imaging. And that concludes our module on low back pain.